Good evening. Welcome to Health Plus Weekly. I am Pete Koheno, your host for tonight. With me is Dr. John Podkowa. He's a primary care doctor located in Fairhaven. And Michael C., who is a certified diabetes educator.
Right, Peter.
Yes.
Right.
So we're here today to talk about diabetes. And not just diabetes in general. It is Diabetes Awareness Week.
Month, and yesterday was World Diabetes Day. November 14th is World Diabetes Day, so that was yesterday.
So I knew it was one of those, either the week or the day that we were right upon. But we want to talk about diabetes, but Dr. Podkowa is here as well to talk about any kind of general health questions that you might have. Feel free to send any questions that you have. We will try our best to answer them. If some are too specific, we'll kind of give some general answers, but we really want this to be an interactive show that gives you the opportunity to have a conversation with a doctor or an expert in a particular field like diabetes, like Michael is, from your phone, from your laptop. It's an opportunity that most people don't get, so we're hoping that you take advantage of it and you send along your questions. So let's start by first having our guests introduce themselves a little bit. Dr. Podkowa, if you don't mind going first.
Sure. Thanks, Pete. Again, my name is John Podkowa. I'm a general internist in Fairhaven. I've been practicing in the communities for about 9 years. I have many patients who have diabetes. I was interested in coming on the show tonight to kind of help talk about the misconceptions about it and kind of field a lot of kind of discussion regarding misconceptions, I think, and so I think we could do a good job of it tonight.
Yeah.
And Michael?
So my name is Michael C. I'm a diabetes educator, as Peter mentioned. I've been in the diabetes field for over 10 years. Been with Southcoast for almost 5 years now, and we have 5 offices throughout the Southcoast region, from Portsmouth, Rhode Island, to Fairhaven, to Fall River, to Wareham. So we have a pretty comprehensive team of educators, nurses, dietitians, and working with our primary care providers and our specialists. So every day is Diabetes Day for me, but yesterday was particularly a special day. I mean, it's a condition that is out there. Everybody knows somebody that has diabetes in their family. So we work with patients to prevent, treat, and manage diabetes.
So Michael, why is diabetes so prevalent in our area in particular?
Well, I mean, there are cultural, there are lifestyle factors that influence it. So how we move our body, what we eat, how we care for ourselves. So in the Commonwealth, the South Coast region is probably the 3rd highest incidence and prevalence of diabetes in the state. So, it's mostly a cultural, it's a lifestyle, there's some genetic factors go into it. Mm-hmm. And there's a greater awareness on providers, in diagnosing early and treating, as opposed to, maybe 5 or 10 years ago, there wasn't that urgency to manage, be proactive in terms of diabetes. And would you say that's the case?
I do, and I think, Mike, it's not only unique to our area. It's not, unfortunately, been a kind of an explosion in diabetes over the past number of years nationwide. Correct?
Yeah, I mean the statistics bear that out. Every year they come out. So there's about 30 million Americans that have diabetes. There's about 90 million that have pre-diabetes. So one in 3 adults either have diabetes or are at risk of it, and there are factors that contribute to that. And so, there's and the cost associated with it. Diabetes is one of the most costly, both in terms of health considerations and dollars to the healthcare system. So,
Why is that?
Well, some of the comorbidities that are associated with diabetes,
Mm-hmm.
Certainly the medication therapies, the frequent visits to physicians, the lab works, and then some of the, as diabetes progresses, some of the complications associated with it, whether it's cardiovascular disease, kidney disease, nerve disease, eye diseases. These aren't initially during the initial phases, but as the condition progresses, and if you put hypertension and elevated cholesterol, like this constellation of risk factors that many people with diabetes have, it's a large health burden.
People, in terms of often wonder about, do I have diabetes? Unfortunately, for a lot of people, it's a silent disease, and it's one of those diseases that is tricky because some people have symptoms from it, and Mike, we can talk about that, right? But a lot of people don't, and it can go undiagnosed for a long period of time. So, if you're overweight and above the age of 25 and you're seeing your doctor, you should probably ask about being screened for it. And there's a couple simple ways to do it via blood tests. I use the hemoglobin A1C. I don't know if you want to try to explain to people. It's always a challenge in a way to kind of explaining the hemoglobin A1C.
Yeah, so there are a number of ways to diagnose diabetes. Sometimes there are symptoms present, frequent urination or thirst or unexplained weight loss or an infection that may be out of the ordinary. Maybe it's a urinary tract infection, but these are seldom, patients seldom present with those symptoms. They present more. Maybe it's fatigue, but it's unexplained. Or so you're right. It doesn't. If diabetes hurt, it would probably be diagnosed more readily. So now we rely on more of a hemoglobin A1C, which is just that you're looking at a lab value, looking at your average blood sugar over the previous 2 to 3 months. So when my first exposure to diabetes was 40 years ago, my grandmother had the touch of the sugar. But, then we had maybe 1 or 2 therapies and insulin, and we didn't have these tests. So now, then there used to be a 3-hour oral glucose tolerance test, but that was a burdensome, time-consuming test. So now we go into more fasting blood sugars. We do hemoglobin A1C. It's simple. It doesn't require fasting. It's a panel that any provider would do. And there are some ways even before that he had mentioned, there are risk factors, looking at your age, looking at your body mass index or your weight. Do you have hypertension? Do you have a family history? Are you a woman I had 2 women today that had histories of gestational diabetes.
That's a big one, yeah.
So now, they're borderline. I think one had 14 years ago, she had a pregnancy with her son, and now she's presenting with the early onset of diabetes. So these kind of factors that can be identified.
I try to talk to patients and empower them or educate them on how they can help kind of control their health or be proactive in managing it. And to what you just mentioned before about knowing your family history is really important in talking to your siblings and your parents if they're still alive and their parents, because there are many things that are hereditary. There are many things that are not, but diabetes is certain types of diabetes are have strong hereditary correlations. So if your parents were diabetics or your grandparents, like what you said, it raises your risk, and you should be aware of that. And if you add in then, if you are perhaps overweight or worse, or aren't that active like many of us aren't, it increases it. So wouldn't you agree in terms of, I think, and gestational diabetes, you said that's a big thing.
Yeah, certainly, many people believe that, they had family history, it's going to run in their family. Well, that's not necessary. There are a lot of genetic factors that are associated with, with diabetes. None of them are predominant. There's some 80 genetic alleles that contribute to diabetes, and none of them are prominent. But, you put a genetic predisposition on a lifestyle, habits that are, in terms of our fast pace, fast food, sedentary lifestyle. And then you have, you have a recipe for, you have the genetic risk, and then you have the lifestyle, and sure enough, diabetes is peeking its head around the corner.
How important is being active? I know that's something that we've talked about in the past. That can you exercise your way out of diabetes?
Oh yeah, certainly it's not if you're eating anything you want, but it's the combination. Certainly physical activity is at the foundation of diabetes management, with how we move our body. This day and age, most people sit at desks, or very sedentary. I saw a landscaper today, and he's fortunate that he's very active, and But the vast majority of people's work and lifestyle is very sedentary. There are ways, activity trackers have become very popular and to quantify our activity. And we know that, sitting, breaking up our periods of sitting with activity. So, there's exercise, there's physical activity. So it certainly is. And yeah, you can. It depends where you are in the continuum of diabetes. And even I had a patient today, she was, I have to lose weight. And I was talking about, even if you didn't lose weight, but you remained physically active, there's tremendous health benefits associated with that. So, but we can, it's exercise with what we eat, our sleeping patterns, our stress management, a whole host of variables, but it's at the foundation. So the recommendations are, to work to 30 minutes most days of the week of moderate physical activity. The vast majority of people don't do that, but if I talked to her about getting on her activity tracker, she said she had been doing it and she was going to start 10 minutes. So 10 minutes are better than no minutes.
Excellent. Comment here from Susan, talking about how important it is to get to know your patients, to be kind, supportive, to really know their full history. As a PCP, Dr. Podkowa, I know that can be difficult because you see so many patients in a day. But what do you do to really be able to drill down into the history of your patients to see if diabetes is potentially something that's bothering them health-wise?
When you meet new patients and then after, I think it is really important to know who they are. I like to find out, first, what their social history is in terms of are they single, are they married, depending on how old they are, do they have children, what do they do for a living? These are important questions to, like Michael said, because if someone is a gym teacher or a landscaper or you kind of in my back of my mind knows that they're likely moving more than I am during the day because I am not very active in the course of my day. If you were a type of person who's professional, you're behind a desk, and you're probably not moving that much. You ask about family history. I always do with my patients to find out how are your parents, what diseases have run, because it also frames risks that they may have, experiences they may have. Like you said, like I had like you said, your grandmother had the diabetes. Like illnesses shape people's perception of disease in the family in a lot of ways. So you learn these things. I like to ask, what people like to do in terms of hobbies, and then you go into their medical history. So it's really important to kind of figure out who the people are first, and then it helps you know them and remember them and how they approach their life, their health, how I will help them approach their life and their health is going forward is super important.
Another question from Donna. She is asking, is prediabetes a diagnosis? And if so, what does this actually mean? And I'll leave it up to one of the two of you to answer.
Yeah, I mean, there's the term prediabetes is becoming more common. I mean, it is a diagnosis. I mean, it's an A1C of 5.7 to 6.4. It's a fasting blood sugar of 100 to 126 repeated twice. It's so there are diagnostic criteria. I'm involved in there was 10 years ago there was a program, and the Y is at the leader, the diabetes prevention program. So we have 90 million Americans that have prediabetes in this country, 1 in 3. It affects our older adults more, and so at a great cost. And we know that over the next 3 to 5 years, a high percentage of these people will convert from prediabetes. Now, can we always tell who they are? No, we can if we ask the right questions, but we can't with any certainty. But yeah, so over 10 years ago, there was a program called the Diabetes Prevention Program. It was over 3,000 multicultural, diverse age people, and they looked at it was what we call a proof of concept study, and they wanted to compare metformin 850 milligrams twice a day to a placebo, to an intensive lifestyle program that consists of dietary modifications, 150 minutes of physical activity with the goal of losing 7%. Doesn't sound like much, but 7% of weight loss, and sure enough, the lifestyle program cohort had a 61% reduction in diabetes after 3 years. So this program went from a proof of concept to a national program, one that starting in 2018 Medicare will cover. So it is a diagnosis. I see patients that providers will send to me that are at great risk. I mean, I had a patient today, my last patient, he was a smoker, he had an A1C of 6.4, hypertension. He happened to be a landscaper, which was good, but that was to his advantage. But he's a high-risk individual. Now, if somebody will send me a 79-year-old woman, with an A1C of 6.4, and I'm not so concerned if, they may, assuming there are other health issues. So we've got to put it in the context of the individual. But, think of the age, the gender, family history, and all these factors.
And I think I agree with Michael. It certainly is a diagnosis. I try to motivate, almost all of my patients depending on, their health. But if they are overweight, if they need to lose weight, if they need to exercise more, and I can say, if you mention that and you do a blood test and they are a pre-diabetic or even early diabetic, in some ways people think it's the worst news. But for a lot of my patients, it becomes actually one of the best things that happen because it motivates them. It shows that your body is on the cusp of perhaps turning a corner you don't want to turn, and you can intervene, like the trial showed, which is amazing. Mm-hmm. Losing, and it leads to another question, is how much weight do I need to lose? People get worried, and looking at losing weight, it's really kind of overwhelming, and they'll unfortunately go somewhere and they say, you need to lose 75 pounds, or to be, but the reality is what Michael said, 7 to 10% drop in your weight makes significant improvements in your body's processing of blood sugars, cholesterol, and a variety of things. And so that's pretty manageable for people to wrap their mind around, which is it's a really empowering thing to bring people. So yes, just because you have pre-diabetes, like Michael said, doesn't mean that you are hurtling towards the diagnosis, that you could act, intervene, make lifestyle changes, which is great.
Community health workers have become more common in the healthcare industry. In particular, I know Southcoast, we're using them for diabetes. I believe that I've run across a patient of yours in the past that you referred to a community health worker. Can you just kind of talk from your perspective as a doctor, as a PCP, maybe just give a little background on what a community health worker is, and then how you use them to help manage some of your more difficult cases?
I think community health workers are one of the favorite aspects of my practice that I have the privilege of working with. I was able to work with them through a grant Southcoast got through a couple different insurance companies. These are men and women who are interested in helping people and passionate about helping people. They get training in a variety of different things. The diabetic community health workers go through. Are you involved in teaching them? I think they go through classes.
We
right?
work with them.
Right?
Yeah, we work with them.
And they learn about it, and they go and they work with my patients and other doctors' patients who are having a hard time for a variety of reasons. Maybe they live alone. Maybe they don't have access to a good grocery store. Maybe they don't know what type of food to buy. I mean, we can talk about it. It's a really common thing that people don't know what to do. And they help some of my patients just stay on track. They're like a really great friend. The way I think about it, in a way, they are. They're like, we all have good friends and bad friends, and they're fun. You know what I mean? But and sometimes the choices we make are dictated by the type of friends we're surrounded with. I know I have that. And they're just a really good ally in certain people's lives to make good decisions when you're down in the dumps, and maybe you need a bit of a pick-me-up. Maybe you need someone to help you show what food to buy. Maybe you need just a reminder that your doctor appointment's coming up and you should go. And they are just what I call high-touch individuals who help people. I see patients in the office maybe depending on how good or bad they're doing, every 2, 3, 6 months. But these people are in their lives almost a couple times a week or even more. And so they are tremendously important in improving people's lives, especially when it comes to diabetes, especially new diabetics or when they don't understand. So much of it is choices and lifestyle, wouldn't you? I mean, you agree?
Yeah, I mean, this is a whole new level of allied health care professional. They live in these communities, they work in these communities, the barriers, the obstacles. So some of our most challenging patients, often some of the things we didn't talk about is social support is critical. Often, I'm sure you find that out. Do you have husband or wife or
Yes.
family. What's the family structure like? And that can be to your advantage or it can be very detrimental. Sometimes it can be, obstacles to overcome when you have family dynamics that, aren't conducive to healthy living. So, they're critical. They sit in appointments with me and the patients that I had earlier this week, and they're working with them to navigate whether it's food access or communicating with the providers. So, they're critical to certain patient populations.
I feel so lucky to be a doctor, a primary care doctor at an organization like Southcoast, to have Michael and his team of diabetic educators, community health workers, because it's a complicated disease. It doesn't fit well into a 15, 30, even a 40-minute visit one time with me. There's lots of questions. People learn differently from one another. And the impact that the diabetic education team plus these community health workers have made, it's just phenomenal. Because patients are really wonderful. They come to see me. They don't want to disappoint their doctors. They're nice. I try to explain things, and they nod their head, and and most of them are listening, but they're embarrassed sometimes. They don't know the right questions. I'm like, how you doing? How's your diet? And they're like, oh, it's great. I'm not eating any sugar. And you can talk about this, like
Right.
the common misconceptions of what people think they should and shouldn't be eating even, And I'm like, okay, well, what are you eating? And I'm just sticking to pasta or, or potatoes in this community, right? And you're like, okay, well, and that's like, I guess the question for you is like, what do you see as the most common misconceptions of people who are struggling with their sugars, eating and not eating in a way? Do you see that a lot? Or
Well, I think sugar-sweetened beverages is probably one of the biggest ones, and refined carbohydrates. So, and there's some myths. I had a patient yesterday, I was talking about what does she have for breakfast, and we were thinking about, what she could, something that's portable and easy. And I said, how about a hard-boiled egg, a piece of fruit and toast? And she goes, well, isn't that egg going to increase my cholesterol? Is that not good? And then we went on to find out that, she had just had a coffee, iced coffee and a chocolate donut. So, did she not know that? She probably knew that the chocolate donut probably wasn't the best option. So, what we've got to do is what's a good option for you and have her explore that.
Yeah.
Maybe she didn't like eggs. So it's really the question you ask. And then I'm sure Dr. Podkowa, the most important thing is how he listens. How he listens, what is that piece of, information that I can build upon and collaborate with my patient.
So Susan's sharing that she feels that dietary counselors are a big help, as are food trackers. And then we have a question from Tricia, which Tricia, I don't want to get too specific with the docs here on some of the details that you've sent over, but to answer your more overarching question, what is considered a normal range for your levels? Do they vary depending on person? What are the factors?
Yeah. So, big thing in diabetes now is individualization. It's not one size fits all. We've got to work with our patient. How motivated are they? How long have they had diabetes? What are their other health issues? But, in terms of, self-monitoring blood sugar is important, done appropriately. So, we're looking. Again, I don't know, but, there are different guidelines for different organizations, but we're probably looking at pre-meal blood sugars to be less than 130, and 2 hour post-meal when our blood sugars are apt to be the highest, probably about 160, 180. Now, if this person has an A1C of 10, which is consistent with an average blood sugar of 250, they may be going to 350, 400. But that's what, I'll work with my patients, and then we'll work on physical activity. We'll work on what they eat and how much they eat. And then, the fourth leg is medication. What are the therapy options, used appropriately. Well-controlled diabetes is the cause of nothing. So if we control the ABCs, right, your A1C, your blood pressure, your cholesterol, and smoking, chances are there aren't going to be any adverse health issues associated with diabetes.
And so I'll show my clinical ignorance here. Thyroid level, is that diabetes related, or is that more a question for you?
It is an endocrine or a hormone problem or question. Our thyroid regulates our metabolism. It's not specific to diabetes, but diabetes is a disease of another endocrine system, so you would want to make sure that there isn't multiple problems going on. And so in my patients who are overweight or do have diabetes, in addition to screening for diabetes, I often look to make sure that there isn't an underlying thyroid disorder complicating things as well. And
same type of question, is there a standard range that people should be in, or is that kind of a not a one size fits all type of
It varies. There's several different ways to manage or to measure your thyroid function. The most common one is a test called a thyroid stimulating hormone, and there is a normal range for that you should fall into, and that's much more kind of, I think, fixed versus the ideal blood sugar control that Michael's talking about based on other people's ages and medications and different things. Yeah.
And so if someone feels they have a higher thyroid level than maybe the material they're reading of what a normal level is, but their doctor's telling them that level is fine, what would you recommend to that person to put them at ease? Would you tell them that they maybe should get a second opinion?
Yeah, so people have lots of questions on thyroids. Often, what prompts people to worry about their thyroid is, are they tired? Do they have a loss of energy? Are they overweight? Are they struggling to kind of lose weight? Or are they losing weight on, so problems of an underactive thyroid would typically be, loss of energy, trouble losing weight if you're overweight, appetite changes, possibly some constipation. If your thyroid is overactive, sometimes people complain of unintentional weight loss, perhaps diarrhea, increased appetite, hair loss. Hair loss can go with high or low thyroids. So people, and you check these things, and there's a range. And sometimes, a lot of the times, the tests come back normal, and a lot of people are frustrated. They're like, why can't I lose weight? Or why am I still overweight? And why don't I have any energy? And sometimes it's fine to seek a second opinion, to have a second set of eyes on it, because there are nuances of thyroid tests. But I tell my patients a lot of times, don't just get hung up on that. Just because your thyroid may be normal, and it may seem like, because it could be causing your problem, but actually it could be something else. So let's dig deeper. Let's look behind that, For the fatigue or for the weight loss, and kind of bringing it back to the diabetes, make sure your blood sugars have been checked, because it could be your blood sugars that are off that are maybe causing some of your problems, and not your thyroid. I see this a lot. So yes, you want to be thorough. Yes, you want a second opinion. But if your thyroid has been checked a couple different times and it's not the problem and you're not feeling well, it's really important to talk with your doctor that maybe, okay, what else could be driving this? Because there could be something else.
We're going to take just a 60-second break here. We have questions from Elaine and Susan that we will get to right after. Josh, you play video number 1, please.
People, actually come up and they're like, I gotta hug you. And it's like, this is the first time in, X amount of years I've not been in pain. And we get that feedback every single week. Integrating the nurses, integrating physical therapy, that is all part of the treatment strategy, the treatment algorithm. In a matter of weeks, matter of months, they're now able to have the life that they want to live. And that's really more than medicine.
So, welcome back. Here again with Dr. John Podkowa, who is a primary care doctor, and Michael C., who is a certified diabetes educator for the entire system, really, correct? Dr. Podkowa is located in Fairhaven at our primary care and specialty care center on Mill Road. So, questions for you, Dr. Podkowa. First one is, what are your thoughts regarding the new guidelines for high blood pressure?
Great question. I just saw, just read them this week. They come out, I think, by the American College of Cardiology. And it was it was a change. They lowered, traditionally the definition of high blood pressure was a top number of greater than 140 and a bottom number above 90. The top number is called systolic blood pressure, the bottom number is diastolic. People always ask me, what does that mean? The systolic number is when the heart contracts and beats. The bottom number is when the heart relaxes, and that's the pressure difference as the blood goes through the body. They lowered them to 130 over 80. Anyone with a blood pressure above 130 over 80 is now hypertensive. So that's a change. It'll put millions more people in the diagnosis of high blood pressure. Why do we worry about high blood pressure? And why do we? It's because it's a leading cause of death in the world. Stroke, heart disease, kidney disease, peripheral vascular disease. So it's an important diagnosis. I think some other societies are going to come out with their recommendations, and we'll see whether the medication changes will go along with these new diagnoses. Like diabetes that we've been talking about earlier, high blood pressure is another often silent disease, which are very dangerous. So people wonder, why do I have to see my doctor? I feel fine. I haven't seen my doctors in years. It's okay. I feel great. The unfortunate reality is there are a host of diseases that can happen in the background that could be seriously affecting your health and putting you at risk for things that could easily be prevented. High blood pressure diabetes is one of them. So making sure you know what your blood pressure is, making sure you know what your blood sugars are if you're at risk for diabetes is important.
So question from Susan, and actually two questions from Susan. I'm not sure if they're completely related, but the first is about I assume it means that her son, who is 11, is suffering from arthritis, and she is asking about a limitation in medication that her son's receiving. They're can either use Tylenol with heat or cold. She says, and is wondering why there's not more options for that pain.
Yeah, unfortunately, Susan, I am a general internist, and I don't have training in pediatric care, so I can't answer that one tonight.
And she's also asking about diabetic neuropathy. What can help with the nerve pain?
Yeah, diabetic neuropathy is a fairly common complication. So this can be either pin needles in the extremities, primarily the feet, or loss of sensation. Although we need to make sure we get a confirmed diagnosis. There can other things be kind of pseudo-neuropathy. So, it's important that, you have your provider inspect your feet. So, shoes come off, socks come off. And there are some fairly simple tests that the doctor will do, a monofilament test or reflex test. So, and in terms of the problem is we really don't have, treatments, improved glycemic control, improved blood pressure, blood sugar control. So we usually will treat it with certain classifications of medications if it's problematic. Good foot care is critical. I know I saw a patient earlier this week. I think his nails are coming off and he's got a fungus. This is a setting for more advanced problems, if not addressed. Mm-hmm. So we really need to take care of our feet. It's often neglected, just like take care of our feet, regular annual eye exam. All these preventative measures really go a long way to preventing long-term problems. So you need an accurate diagnosis, and then you need to have a discussion, with your provider. What are the treatment? If it becomes extreme, you can be referred to a neurologist, if appropriate. But good blood pressure, blood sugar control, don't smoke, and these types of things.
It's a good question because often you're talking about if you can't feel diabetes a lot of the times, or you can't feel high blood pressure a lot of the times, why do we need to worry about it? Patients ask that. So why am I going crazy? Like, why do I have to exercise more? I feel okay. I don't have any headaches. My energy level is actually fine. And it goes to, Mike, we talk about what happens if you don't take care of your blood sugars long term. And that's why we worry about these. It can lead to a host of things that can become problematic. Number one, it dramatically increases your risk of heart disease, and heart disease is a leading cause of death in this country. Actually, in Massachusetts, it's cancer and heart disease are neck and neck. But so diabetes, if it puts you at higher risk for heart disease. So what Michael said, so if you're diabetic, you want to make sure you control as many factors that can lower your risk of heart disease. So not smoking is just the number one thing across the board to improve anyone's health. Controlling your blood pressure, making sure your cholesterol is under control. What else, Michael? Long-term, and why do we, other long-term, if you don't control the peripheral neuropathy, your pain in your legs from the nerve damage is what, the one call or the one, person just said about, but there's some other things, right, that happen.
Oh yeah, I mean, there, kidney function. So, but I think you talked to a good point. Pain. Diabetes isn't painful for the most part. For the onset of it isn't. They often have a constellation of other risk factors, and why do I need to be concerned about it? Well, because I don't have a crystal ball. I can't tell how this is going to progress. But I can assure you that if you manage it proactively, it's not going to become a problem. But people don't see the urgency sometimes. And it's not making drastic. Often it's making. I see the biggest changes just with the breakfast people eat and the beverages people drink can have a profound effect. Now we got to look at things like sleeping is critical, and then the other thing is people's evening, their snack habits. They have dinner and then they don't eat breakfast, they don't eat lunch, they have dinner and then they have another snack, and they're grazing throughout the night. Yeah. So some of these just changing our eating patterns, maybe making some small changes can have profound effects early on.
So speaking of eating habits, I want to go back to something we talked about a little bit earlier, and that was you talked about people thinking that as long as they avoided sugar, that they would be okay, but then mentioning that they were eating pasta, things like that. Can you maybe explain for those? I mean, it might seem obvious to some what the connection is there, but if you don't mind kind of breaking down, why that is problematic.
So I'm not a dietitian, but I obviously work with patients because I think that's at the foundation, the foods we eat. So any program really works, whether it's the Mediterranean diet, whether it's a low carb diet, or they all work if sustained. So we need to find what's sustainable. There's certain things we do know. We want to cut back on refined sugars in our diet. So that'd be brown sugar, molasses, white sugar. So processed sugars are at the
high fructose corn syrup.
High fructose corn syrup, right? So we want to limit processed carbohydrates. So refined breads and sweets, muffins and donuts. And then the added sugars that may be in drinks, iced coffees and the syrups that tend to be, sugar, high in sugar. In terms of, pastas and rice, food's a matter of choice and portion. So I have some patients, they don't want to give up certain things. So then we talk about, what's an appropriate portion size. So if we can go from, white pasta to whole wheat pasta, if we can go from white rice to another whole grain like a barley or a brown rice. Some people are doing cauliflower rice. It really depends where creating an awareness and then seeing where that will take you. But we really want to limit process. We don't want to have our food out of a bag or a window for the most part, because that's generally high processed foods, high in fat and stuff like that. Not that we can't eat healthy, on the go and eating fast food or something like that, but we have to make a conscious effort to make good choices.
I always try to tell my patients and kind of try to boil it down into simple things, but you're doing pretty well if you can name all the ingredients in the food that you're eating, right? Like I think
that's pretty good.
It's not always easy, but for the most part, if most of the food you're eating, all the ingredients in, and I have some patients who have really good memories who can rattle off, like my kids can do this as well. Like, well, Dad, I know what's in Doritos, and they memorize, and that's not,
chemicals,
but,
yeah.
But if you have a good understanding and you know all the ingredients, you're eating something probably for the most part.
Then we want to eat things that have lots of color, fruits and vegetables, right, that come from the God's earth, right, and don't come from a factory or something like that. So, but we're bound to. Some people are, and we just need to, read the ingredients, look at our portion size. So, this is a whole conversation about this, we can have, but those are some simple take home thoughts.
Yeah.
And none of us are, nutrition experts per se, but I think we know that generally speaking that when you eat a carb like pasta, when it's broken down by the body, it ends up kind of having the same effect that a simple sugar does that you have in your body too. It's broken down into glucose, right? And then it's your body kind of treats it similar.
Yeah,
to
more,
the
and some
sugars.
people are glucose intolerant,
Yeah.
right? Some people can't handle that. One person could, and one person could handle it, and another people can't. So that person that can handle is likely at risk of diabetes. So we want to, eliminate, I call naked carbs. So we don't want to have things that are just carbohydrate. We want to combine it with protein and fat, to affect the digestion and so forth.
It's interesting. It brings up a lot of questions people have for me in terms of there's different types of diabetes. And some people ask me, do I have juvenile diabetes, or type 2 diabetes, or and so there are differences in terms of the way your body handles sugars, which made me think about this, right? We can talk about, maybe you can explain that type 1 diabetic and type 2 diabetic, and because it's very different diseases, right? And
They're totally different, but
Yeah.
they're both called diabetes. So, type 1, or what used to be called juvenile diabetes, because it was traditionally diagnosed, in the early teen years, but not necessarily so. So the body, it's an autoimmune. I had a gentleman today, 32, I saw. He's an Indian gentleman. He was frequently, he just moved here from India, and he was going to the bathroom frequently. He had unexplained weight loss and thirst, and he didn't have a primary care provider. And, he went in, and his A1C was 11.4, and it's highly he's a slender Indian gentleman, and it's highly likely that he has type 1. Now they haven't done the differential, the test to confirm but it appears as though, so they started him on insulin. So this only represents about 5% of the population is type 1. It can onset at any time. It may present a little differently later in life, but usually there's thirst, frequent urination, unexplained weight loss.
And what happens, right, is the body unfortunately turns against itself when one of those autoimmune diseases where the body, for some reason, goes to, kind of at war with itself and attacks. This time the immune system attacks the pancreas, which is the organ in our body that makes insulin. And, correct me if I'm wrong, like insulin is helps move blood sugars from our blood into our cells, because our cells all need sugars to run on, especially our brain, and that's why we need to eat, and that's why we need blood sugars to run our cells. It's basically the gasoline of our body. And I always try to tell my patients, and you can maybe correct me if I'm wrong, and hopefully I'm not in front of live people here, but I set this analogy up of of a gas station in a way, and if your car is your body or your cell, the gasoline is the sugar, which is under the ground, and insulin is the gas pump, and it takes it from under the ground and puts it into your car, right? And
you can look at it anyway. I say it's the key, to the door.
Yep.
Insulin allows the glucose to get into the cell, and our brain needs glucose to function. It's stored in our muscles and our liver, and if we have too much insulin and glucose, fat. And so that's type 1, and it's an autoimmune. The body's not producing insulin,
So it stops producing the
so
insulin.
it stops. Type 2, there's some degree of insulin deficiency, but there's insulin resistance. So the body's producing insulin, but it's not effectively using it, perhaps because of obesity, excess weight, and so forth. So and that represents about 95%. And there's of the diabetic people with diabetes. And then there's gestational. There's other types of diabetes secondary to other conditions like pancreatitis or something like that. But that tends to be a small fraction.
Very cool comment here from a patient of yours, Dr. Podkowa, Matt Hill, who says that your diagnosis of his low blood sugar, you put him on fiber therapy, and it's helped significantly, and he thanks you.
Hello, Matt.
And then we just have a comment here from Jose, who just says that you're his doctor and you're awesome. So Just want to pass those along to you.
Thank you. It's interesting with the fiber, though. My patients, I recommend Metamucil a lot, which helps for a variety of reasons. It's a fiber supplement. No one really wants to hear it, but I think people think I'm kind of obsessed with it. But it's a really nice thing. People can drink, add to their diet. It helps with weight loss. It helps actually regulate blood sugars because it slows the food through the colon and delays the absorption of some of the sugars, which helps make people feel better, helps control diabetes, actually lowers cholesterol, protects you from a variety of things. So I can't say enough good things about fiber in a high fiber diet, and one easy way to get it if you don't eat a lot of high fiber foods and vegetables, as I recommend metformin. So, not metformin. I'm sorry, Metamucil.
Is it okay to use a supplement? Are you going to get the same benefits from a supplement as a fruit or vegetable? Or
so I'm a big get it from the source proponent. I really am. I just think that's the best. But I think if you don't, some people don't like a lot of fruits and vegetables. I recommend it. And I recommend it even if you are getting a lot of fruits and vegetables too. But ideally, the best case scenario is you're eating majority of your diet is plant-based fruits and vegetables. I think there's really, really good evidence that people who live long, healthy, happy lives eat mostly, kind of a plant-based vegetarian diet.
So this might be more a question for a dietitian, but I'll ask and feel free to say that it's not up your alley. But there's a question here about CBD oil. I'm not sure. Is that cannabis? Is that cannabinoid oil? And the benefits on it, thoughts on it? Anyone want to tackle that? Or
no, I'm not familiar. I mean, there are some supplements that in the area of diabetes. So vinegar, right? I mean, sometimes some people will take some apple cider vinegar. It has proven efficacy in terms of attenuating our post-meal spike. So I'll do that. Obviously, some people have heard about cinnamon. The jury's out on that.
I was going to ask you, what is your
I mean,
cinnamon?
it's
I have a lot of
not,
people who are
it's
taking
not,
cinnamon.
No. But apple cider
Oh, that's so
vinegar is.
funny.
I am not familiar with this. I mean, the area of supplements and herbs, and it's a specialty unto itself. Yeah. And certainly, a lot of medications are based on the properties of these types of things. But
when you're getting into cannabis and marijuana, it's hard to really advocate for those things as they continue to be generally illegal and still regulated highly. I know that obviously in Massachusetts here, making some headway on that, but
I don't prescribe any cannabis. I can say a couple things I know for sure. Smoking anything is terrible for most people. I think there are clearly exceptions. People who have kind of non-curable cancers, who have limited kind of length of life left because of certain diseases. I think there's been an exception, but for the most people, if you have a relatively normal life expectancy, I can't comment on necessarily the pros and cons of marijuana or cannabis, but I can certainly say smoking, I think raises your risk of heart disease, cancer, and a host of other ailments, respiratory infections, illnesses, exponentially. So I can clearly say that, regardless of what you're smoking. Yes.
So let's move on to the next question from Lee. What's good for inflammation? And I think it would be fibromyalgia. Maybe she was going to be here.
So it's there are a number of things that can cause inflammation, which is in a body's immune response. So it's a difficult question to answer. The first question would be to find out what's driving the inflammation. Is it an infection, like perhaps a Lyme disease or a tick-borne illness? Is it an autoimmune process like lupus or rheumatoid arthritis? Is it a vascular problem, like a vasculitis or a breakdown of cells? Is it heart disease can cause inflammation? Is it a disease like fibromyalgia that raises the sensitivity of the body? So number one is to figure out what's driving the inflammation first, and then two, depending on that, you can address how to calm it down. If it's an arthritis, maybe an anti-inflammatory medication, ibuprofen, naproxen, or Aleve, or some stronger medications. Fibromyalgia, there are other medications that Cymbalta or duloxetine is one of the common medications that are used. But I think the most important question first is what's driving the inflammation, what's causing it.
So we have about 10 minutes left. Michael, we've all caught up on questions right now. Michael, is there anything that we haven't covered yet, specific diabetes that you think is important that you'd like the viewers
Well,
to?
I just, the foundation is what we eat and how much we eat, and understanding that there's no perfect diet, but there's things we can do to progress. And certainly always, taking, if you have questions about, everybody, diets work for everybody if you follow them, getting working with somebody that's trained, working with your nutrition. One of the most easiest things to do is just, write down what you're eating. It keeps it very mindful of what you're eating. Do I want that? Am I hungry? So become in touch with, are you hungry, what you're eating, why you're eating it. How we move our body. So whether we move throughout the course of the day or whether we do bouts of exercise and the combination of both. Then monitoring your blood sugar is an important component for some people, a meter. Some providers may not worry, but I think more and more we're, monitoring our blood sugar either periodically before a meal or fasting or at bedtime or 2 hours after a meal can tell us a lot about your physiology and how your body handles things. And then fourth, we have a dozen medication therapy options. Not that we want to optimize our diet and exercise, but in some cases they don't produce insulin or whatever. So we need, we have therapeutic options. And then talk to your doctor about have questions and collaborate and then ask them to be referred to a diabetes educator. I had a patient the other day. He walked out and he goes, boy, that wasn't bad. He was so worried, got himself all worked up. But that was good. That was a compliment. So it means we collaborated, we worked together. And if he walked away with one thing, then we were successful.
Thank you. Dr. Podkowa. Question from another patient who's a big fan. This is from Suzanne Souza, who was a patient of yours for many years, she said. Truly most caring and compassionate physician she has ever met. Have you paying people off?
Thank you, Suzanne. I'll see you tomorrow.
So her question is, she has type 2 diabetes, and why does she get so sleepy after meals? For either of you.
Yeah, that's, classic, it's probably a postprandial excursion. So depending upon the composition, the amount of food she's eating, sometimes we can, when our blood sugar rises rapidly or falls rapidly, that we can experience that as fatigue, right? So, the one way to do is just, look at what she's eating, check her blood sugar 2 hours after, and so, and kind of do some things with her diet. We're working with a dietitian because that's not unusual. Now people also have circadian rhythms, so there are times of day where we tend to have a lull and have more energy or less energy, but certainly the composition, the amount of food we eat can affect our energy level.
I would say, and certainly Suzanne, in to keep track of what, often it's not every time you eat, or maybe it is, we can talk about that, but often maybe to kind of create a food log, which, like I said earlier, and jot down, it may be certain foods that make you more tired than others, and then you can identify what those are and maybe just limit them. Often it's not every time, but so a food diet is a really great way of, even if you're not diabetic, we all feel different, it is, depending on what you eat, you may feel good or bad, and it's really interesting what drives you, how you feel that way. So kind of keeping a food diet is a really interesting way to learn about your own habits, what you're eating, how you're feeling. And there's really good correlation, like bad foods, bad moods. Without a doubt, it's pretty simple.
Awesome. And so I'll give you now the same final word. Anything that we didn't touch upon today that you wanted to?
No, I think it was a great topic to talk about. I think, kind of parting messages that we, like Michael said, we are meant to move. I think one thing I said to my patients and try to, and try to impress more of the time, we are meant to stay active. We are meant to move. As we sit and do less, we put a higher risk for diseases like heart disease and diabetes. Gaining weight, we have to watch out. Especially one thing we didn't talk about tonight is, I think, and I'm trying to raise more awareness is where you gain weight is really important. If you gain weight around your midsection and around here where many of us do, it puts you at higher risk for diabetes. The bigger your abdomen is, it increases your risk of insulin resistance and heart disease. And so a lot of people at times get hung up on scales or don't even own scales. And more I'm telling patients, actually just measure around your midsection. If you measure around your midsection, right above your belly button, it actually should be half as many inches as we are tall. It's a really good goal. All right, so if on my best day, with shoes on, I'm 5'10", so you're 70 inches. Around your waist should be 35 inches right above your belly button, because if you're bigger than that, if your weight's around your abdomen, you're at risk for diabetes. And like we talked about, you may not know it. So it leads to another thing is if you don't have a doctor, a primary care doctor, I really recommend, not just because I am one, but to get checked out, because you may, there's some things that you may not be feeling that could be going on in your body that could be made better if we just sooner we catch them.
Excellent. I really enjoyed the conversation. I hope those watching at home did as well. Thank you both so much for being here. Dr. Podkowa, you're going to be a regular moving forward, which I'm very excited about. Welcome. I think it's going to be a great element to have in the show, and I know with the sneak preview that we've got of the fans you have out there, I'm sure there's going to be plenty of people who'll be happy to see you here every week on Health Plus Weekly. Just a little bit of information for next week's show. We're actually going to take next Wednesday off because it's Thanksgiving Eve, a notorious night where folks like to go out and party and catch up with friends from high school they haven't seen for a long time, and we figure you might have other things going on, and so we are going to take the night off, but we will see you back here in 2 weeks for Southcoast Health Plus Weekly. Take care until then, and happy Thanksgiving to everyone. Good night.